Good afternoon, everyone. I'm Raul Santos from the University of São Paulo, and I'm chairing this World Heart Federation session here at ACC 24. It's a real privilege to be here. This session is being recorded, so it's not only us, so it will be available for a lot of people all over the world. And we're going to talk about a very serious disease that is homozygous familial hypercholesterolemia. This session is supported by Regeneron. We'd like to thank the sponsor for giving us the opportunity to address you. And in this panel, I have good friends and very important people, especially our patient with FH, right? So we have Dr. Mary Magone. She's Chief Medical Officer of the Family Heart Foundation here in the US. We have Professor Christy Ballantyne from Baylor College of Medicine in Texas. And we have Ms. Alison Jameson, who works with the FH, Family Heart Foundation, right? And she's a FH patient. So definitely, I guess she's the most important person here with us, okay? So basically what I'll do, we have the three participants. I'll ask them a few questions and we're going to rotate among them. And after we're done, we also might have the opportunity of answering questions from the audience. Please don't be shy on asking them. So HoFH is, as I said, it's a rare disease, but it's a devastating condition, right? These individuals, they are born with extremely high LDL cholesterol levels, and this is associated with a very early onset of cardiovascular complications, not only coronary heart disease, but malignant and, let's say, widespread atherosclerosis to different organs of, and also not only the atherosclerosis, but also aortic valve disease. So it's a very complicated situation. Unfortunately, most people who have the disease are not diagnosed, right? And usually when they're diagnosed, it's really very late, and they already have many consequences of the extremely high LDL cholesterol. On the other hand, the good news now is that we are starting to have very robust and safe therapies for these people. And now we do stuff that we never thought we could be in the past, that is really normalizing LDL cholesterol levels in people with homozygous FH. But I think the challenges are still two, in my opinion. First, to make a real adequate and early diagnosis, and second is the access to the therapies. So definitely these are two things that we must focus in really trying to cope with this disease and reduce the burden of complications and the suffering of all our patients. So okay. I'll start with Mary here. And Mary, you know, you have lots of experience with FH. You work now with a FH patient organization, and definitely I know the amazing job that the Family Heart Foundation does for not only for FH patients in the US, but all over the world. And I'm really thankful for all the service that you do for all of us. And my question to you is okay, so we have this issue of diagnosis. How are the recommendations for that? And I'm going to discuss with you because, you know, this disease needs to be diagnosed very early. We're not talking about children here, right? We're not talking about adults. And there's a lot of controversy regarding recommendations, even in a country like this one, regarding whether we should measure cholesterol in kids or not. So can you talk a little bit about this?
Yeah. Sure. Thank you, Raul. So currently, the American Academy of Pediatrics and the National Heart, Lung, Blood Institute and the ACC, AHA all agree that children from families with early cardiovascular disease and should be screened at around the age of 2. Children from families with familial hypercholesterolemia also should be screened around the age of 2. When we look at universal screening, this should occur between 9 and 11, and again, universal lipid screening between 17 and 21. But how well are we doing in the United States? We're doing very poorly. Our research at the Family Heart Foundation suggests that only between 2 and 22% of children are being screened between 9 and 11, and screening around the age of 2 is vanishingly rare. And so we're missing the opportunity to diagnose these children early. And one way that we might be able to consider screening very early is newborn screening. When we think about newborn screening, 99+% of children, infants, are screened with newborn screening. It does depend on the states. Each state has a different panel of what they screen for newborn screening. But newborn screening would make a huge difference. And we know that there are groups, one at the University of Wisconsin, Amy Peterson, that are working very hard to make newborn screening a reality. But you know, I think that we also need to do a much better job at universal screening of our children between 9 and 11 and really focusing on kids at around the age of 2 if they have a family history. So I think we need to think of creative ways that we can increase screening. And at the Family Heart Foundation, we're working with various groups. We're working with a group at the University of Vermont on universal pediatric screening using point-of-care testing. And I really do think that point-of-care testing, being in your pediatrician's office, getting a finger stick and getting a point-of-care test may allow early diagnosis. So we really have to have an opportunity at many different points to screen. So thanks.
Thank you. So, Christy, you are a physician who's in the front of really treating, identifying, and doing research for people with FH. And my question to you is, what are some key research and policy gaps that must be addressed to pave the way for universal newborn screening for HoFH in the United States? As Mary said, you know, we have to diagnose very early this form of the disease. And if we don't check very young kids, we will miss the opportunity of start treating and changing the natural history of the disease. So can you comment a little bit?
Yeah, I think it's a very important question. And I personally think, Mary, we have enough data to start now. I don't understand why we are not doing this. I did a postdoc in genetics, and in the early 1990s, you know, our genetics group was doing newborn screening for genetic disorders, and Art Baudet said, Christy, should we add LDL receptor mutations? I'm like, oh, well, yeah, of course we should. Why wouldn't we diagnose this at birth if we're doing genetic screening anyway? In the state of Texas, for example, my wife had a nephew who was born, and his mother was saying, this is such a nice baby, he never cries. And then it came back that he had basically congenital hypothyroidism. And if he had not been diagnosed at birth, he would have had the disease cretinism with permanent, basically, brain, dysfunction. Now that's a very rare disorder, but I don't understand why are we not doing the same thing for homozygous FH. So I mean that can be done with a blood spot looking at cholesterol without doing genetic testing. So we should do more research, but I think we should do also the advocacy that some states should start this. I think we have enough research right now to be doing this. In particular, as we have new ways to treat this early, this thing of waiting, it doesn't make sense. Personal opinion, but I do think that we're ready now with enough science to be advocating for policy changes now.
It's for us who see the FH patients, it's really a challenge to really deal with the complications, because as been said here, usually they get to us, especially HoFH patients, very late, and they already have subclinical atherosclerosis or already have aortic valve disease, and sometimes they might even have an MI by the age of, let's say, 13, 15. So it's really a desperate situation, and sincerely, I think that we need to start earlier. And this initiative about newborn screening, it's really growing amongst the specialists, because we certainly know that this usually too late when we make the diagnosis, right? Alison, I really would like you to share your experience with us, because you're a patient, you're someone who has HoFH, right? And so I guess this should have affected your life a lot, right?
Yes, it has. And so I grew up, I was born in Dallas, and so grew up in Texas. Was actually quite fortunate that my family knew we had something. We knew it was related to cholesterol. My paternal grandfather died of a heart attack when he was 48. He had aunts and uncles. My father had aunts and uncles who died of a heart attack very early. And my father had a heart attack when he was 28. So my parents knew that this was in the family, but at their behest, they had myself, my brother, and my sister, our cholesterol checked when I was 5. In my case, I had these spots on my knees and elbows that my parents had taken me to a dermatologist, but were told it was molluscum. So they sort of put that out of their mind. But at 5, my total cholesterol was around 900. And my brother and sister had very high cholesterol, but mine seemed to be different. But as they looked at our history, they didn't see evident heart disease or signs of FH on my mother's side. My maternal grandfather had a heart attack at 54, but he had a stressful job, he smoked, there were other things it was attributed to. So at that time, we were just told I had severe FH, just like my brother and sister had FH. So fortunately, I did start treatment, cholestyramine. I started on Mevacor when I was probably around 11 and did every generation of statin from there. And we did what we could. When I was 13, I was then diagnosed with aortic stenosis, but no one ever made this suggestion that that could be related to my cholesterol. So we just worked, that was something else we were going to keep an eye on. I had this idea that if I could sort of beat my dad's mark, because I started medication so early, that if I could get past 28, maybe we had found a solution here. And when I was 28, I had my first bypass of my LAD and an aortic valve replacement. So that was very upsetting. I sort of didn't hit that milestone, but at the same time, we thought I was dealing with the same thing that my brother and sister were. They got better results from the medication, so there was some questioning of why, what are you doing differently, what are you eating? I met with a lot of dietitians, was not what I was eating. And so when I actually then had a child, my cardiologist told me there's a 50-50 chance that you will pass this on to your child. Since it was post bypass, I only made it to 31 weeks before I started having cardiac complications, and my son was born by emergency C-section 9 weeks early, so there was the trauma of that as well. Then when I was 35, I had moved. I had a new cardiologist who wanted to do a treadmill stress test just to get a baseline. And as I was doing that test, I told him something doesn't feel right and collapsed on the treadmill and had a heart attack and sudden cardiac arrest. And 3 days later, I had my second bypass, this time of the RCA, and a mitral valve replacement. At that point, I then had 2 children, one by birth and one by adoption. And I told my cardiologist, I have to do something else. I can't do this again. My dad had a heart transplant at 48. I don't want to end up in that same place. He found a clinical trial for me, and as part of that trial, I had genetic testing done. And at 35, I was diagnosed with homozygous FH. Even though we knew my whole life I'd had this, it like blew everybody away. All of a sudden, these things made sense. It was why it was different for me than it was for my brother and sister. And that's when I found Family Heart Foundation. That's when I started reaching out, doing my own research and figuring out what I could do. So it made a huge difference for me. I've been in clinical trials essentially since that time, from one to the next. And it changed the world for my entire family. I now know that my son must have FH, and so it makes me able to press for him. Previously, I'd asked pediatricians, can you check his levels? You don't need to do that until he's older. And now I know, no, he does have this, and I need you all to treat him in an effective and aggressive way. So it's one of those, like in hindsight, you see all of the markers there. The only thing that didn't seem to fit was that my mother's side of the family didn't have this evident history that my father's did. But when you look back, my grandfather was 54, and my mother has these painful lumps on her feet. There were some signs there, but we just didn't put all the pieces together. That I think had I been diagnosed earlier, it would have made a difference for myself and for my children and for the rest of my family.
Thank you for your words. You know, and I think this statement that you did, it's extremely important to show how bad this disease is. You know, and why we need to identify it very, very early. So, Mary, we're talking about cholesterol screening. That's something that's really simple. But can you comment a little bit about the possibility of genetic screening? Because what she said to me was very important. Because, okay, we had a very severe hypercholesterolemia with lots of complications, but the diagnosis was not made, right? Okay, Christian and I, we see patients like this every day, and when we see someone with extremely high LDLs over 400, we think about, oh, this should be HoFH, right? But I think the molecular diagnosis has strong implications, not only for the patient, but also for the family. Can you comment a little bit how the access to this here in the US, the costs, if this is reimbursed? Because I think this might have severe implications for taking care of the patients, right?
Yeah, that's absolutely true, Raul. And first of all, let me just say, I feel bad that Allison had to say, we didn't put the pieces together. Well, that's on us. And I'm sorry from the medical community that we didn't put the pieces together either. And it is true that genetic testing is not offered as much in the United States as it is elsewhere. And I think that is changing. Genetic testing is more expensive, but certainly has a strong role, and people should always be offered. I think phenotypically, you had HoFH, and somebody could have made the diagnosis. But offering genetic testing, I think, is really quite important. And one point that I'll make in terms of genetic testing is the more we do, the more we realize the range of lipid values that someone with genetically confirmed HoFH has. And we know from our Cascade FH registry, we have the lowest LDL level in somebody with genetically confirmed HoFH, in this case, biallelic ApoB mutation, was 318. That is a very low LDL. Somebody would have said, that's HeFH. I might have said that myself. And the highest level we had in genetically confirmed biallelic LDL receptor mutations is 1,005 milligrams per deciliter. So that's a huge range. And I do feel that if we're looking at someone suggesting that they might have HoFH, we should offer them genetic testing. It is their choice to have it or not have it. I do find in my own center at Dartmouth, it is getting easier. We do have to go through a sort of onerous prior authorization, but I think it's worthwhile doing. But the point I would make is we should be treating the phenotype. If somebody has the phenotype of FH, HoFH, we should be aggressively treating that patient, and we should be treating them as though they had HoFH.
I fully agree with you, because we treat the phenotype, right? But I guess, as I said before, the molecular diagnosis is extremely important, not only for the patient, but also for the family. And I think that maybe, I might be wrong, but some of the therapies might be, let's say, allowed if you have a molecular diagnosis proving that the person really has that disease, right?
I think that if the clinician says, this person clinically has HoFH, they should be treated. But I think, to your point, Raul, I think that sometimes when someone does have that diagnosis, rock your world. When someone has that diagnosis, it makes people stand up and take notice and maybe very aggressively treat other risk factors, get really more aggressive, and certainly to prescribe the HoFH therapies.
Perfect. So, Christy, the disease is severely underdiagnosed. There's a lot of controversy regarding how to make the diagnosis. But what do you think that would be the immediate and actionable measures that individual states could do to implement and reduce the burden of HoFH here in the US? And I think this can be used as an example for other countries in the world also.
So one of the important things we've talked about is diagnosis of heterozygous or homozygous FH just by a lipid profile. And the American Heart Association, Sam Giddings was the first author of the paper, had some very simple criteria for heterozygous FH. LDL over 190 with a family history of premature heart disease or a family history of high cholesterol. Now that is sensitive. It may not be quite as specific, but if someone's LDL is 230, we need to treat that even if it's polygenic. So we'd rather be sensitive than specific. Now, when you see, what was it, 400 or 450? What was it? What was it in Giddings' paper for homozygous FH? Was it 400? So whenever you see an LDL of over 400, you should be thinking homozygous FH. Some of them might be heterozygous, but we want to be more sensitive than you can do the genetic testing. So, we really need to diagnose earlier, and you need to treat anyway. So I think having tests that are sensitive. So what can we do? Well, the other thing that's happening is, so it's very important if we make the diagnosis in the parents. If the parent knows they have heterozygous FH, they are much more likely to be worried that their child and the other partner about could their child have homozygous FH. And I know some individuals are now doing genetic testing for actionable genes so that they would know both, so that's one option. But even a clinical diagnosis, if they have a high cholesterol, the parent should be thinking, okay, our child might have homozygous FH. I think we also do need to be advocating at the state level, and this is where, individuals and organizations, and it needs to be Family Heart, but also organizations like National Lipid Association, ASPC, ACC, AHA, need to advocate in conjunction with Family Heart and patients that some states begin to offer screening at birth. And that's going to be, if it's state by state, it means that it's going to be a scientific / political decision in terms of cost and benefit. But I do think it's also very important, and when these efforts are made, the patient's story is very important for politicians to hear with it. So I guess those are my comments. The better job we do at identifying heterozygous FH, the more the parents will be aware the chance their child could have homozygous FH. And then the other one would be is screening basically all children at birth in terms of efforts for doing that. So I think we're going to have to, I find it difficult to believe 30 years after, I did a postdoc, and when they were saying, should we start genetic testing in newborns, that we're still not doing it. Because the genetic testing now, the price has dropped drastically. Prices are much more reasonable, and, as much money as we spend on a lot of crazy things, we should be doing this.
I think there's something that we must consider also, about the consanguineous marriages, founder effects, right? And especially in a country like the US that receives thousands and thousands of immigrants from different parts of the world. And sometimes, we see this because it's a lot easier to marry to someone that you know, right? Especially if you're coming to a different country. And we must be aware of this, right? And I think one thing that needs to be enforced also is counseling, right? We must talk with our patients about this, right? And as Christy said, so to diagnose HoFH is not rocket science. Just measure cholesterol, check the family history. And this can avoid many severe problems, right? So I think this is extremely important to be considered, and not only I think physicians, but also we must bring this information about the disease to all of us, right? To lay people, because this can really be very, very important for their future lives, right? So Addison, coming back a little bit to you. Your journey is really amazing, right? So not easy, and lots of suffering, right? So as you told us, you had some few misdiagnoses, some weird diseases like molluscum, probably because of the xanthomas, right? severe HoFH. Okay, this is not so bad, right? Because the prognosis is not good also. But how did learning about the HoFH diagnosis affect both you and your family? How might an early diagnosis have implicated in your life?
Yeah. I think diagnosis was very important to me and my family. Like I said, it really explained why my response was not as good as my brother and sisters. For me, that was affirming of it's not that you're doing something wrong, you have a different disease. That allowed me to be empowered to tell a doctor, no, it's not what I'm eating. You know, I have this thing that is different. Since my diagnosis, I have without fail been in a clinical trial for like 13 years now. I think if we had known when I was 5, I probably would have started that earlier. The other thing that, after I got married, my husband was in the Army. We moved every 2 or 3 years. So every 2 or 3 years, I was starting over with a new doctor. And I got a lot of this, let's try this first. Let me see how this works. You're too young to be on this. And I think had I had that diagnosis, I could have pushed back more. I was actually on one of those test periods and not doing LDL apheresis, which I had done for 13 years, at the time of my heart attack. I was in a 3-month review of can we get this down another way. And I think if I hadn't been in that position, if I had been able to say, no, I need this, or the doctor knew that this was the diagnosis and therefore we must be more aggressive, maybe we would have put that off. Maybe that wouldn't have happened. So I think the impact, both psychological and physical for myself, and also for my son, again, like I said, I can advocate on his behalf now that I know that he does carry the gene. So it's had a tremendous impact across multiple generations.
You know, sometimes people don't want to hear about the possibility of having a genetic disease, right? Lots of prejudice, bias, etc., etc., etc. But when we're talking about FH, we're talking about giving the hope of, let's say, a long and normal and healthy life, right? Even with HoFH, that we know it's very hard to deal with, now we can offer a lot. And it's amazing because my eldest patients of FH died by the age of 56. We never thought that they could live until that, because they did every kind of procedure that we had to offer to them, and they did, and they lived long. Because in the past we used to say, oh, these people usually die by the age of 30, right? And nowadays with the newer therapies, people with HoFH can live really long and quality of life and things like that, right? So this is extremely important, and again, to really make the diagnosis, because that and then start early as we can really make a lot of difference, right? So go back to Mary now, right? Okay. So what we're doing here is really advocacy, right? We were fighting for the disease, we're fighting for the patients, we're fighting for access to therapy, and the FH Foundation first was Familial Hypercholesterolemia, now is Family Heart, because it's not only FH, right? We have other genetic diseases that run within the families, and definitely we must fight for these diseases, and especially for the patients, right? So can you comment a little bit on how the Family Heart Foundation is supporting the implementation of guidelines, as well as improving the diagnosis and therapies for people living with HoFH?
Yes, thank you very much. So the Family Heart Foundation uses research, and we use it to promote policy changes and educating clinicians on the consequences of a misdiagnosis. And we use our Cascade FH registry that follows both individuals with HoFH and HeFH longitudinally to do just that. And we looked at our data, recently published our data, all my co-authors here, we recently published our data on the HoFH experience in our registry. And one of the things that really stood out was it's only children at the most extreme LDL levels that are diagnosed early. So to let you know the difference between people diagnosed as adults and people diagnosed as children. The children had a median LDL of 776 milligrams per deciliter. The adults, on the other hand, 533 milligrams per deciliter untreated. So a huge difference, more than 200 milligrams per deciliter. And, you know, I think that what we also saw was not just that high level of LDL, but the consequences of that high level of LDL. So the average age of myocardial infarction, or the average age of cardiovascular event or diagnosis of cardiovascular disease in children was 9. The average age in the adults with HoFH in our registry was 30. Our children had bypass surgery at 6, at 8. We had 5 children whose cardiovascular disease was so severe that they required curative liver transplant. And although it is in ways curative, it's also a very complex thing to live your life having had that procedure. And so we use this information to lobby Congress, to lobby for better therapies, for more research dollars for familial hypercholesterolemia. And we were in fact successful in getting FH in general, but HoFH as well, as a disorder that can be funded through the Department of Defense as an important disorder. And so we brought that information to our colleagues. We have several groups that have gotten grants to study cascade screening, to study other implementation science ways of making diagnosis, making early diagnosis. And so we believe that it's these policy changes that can make a huge difference to getting diagnosis early. So we can support families as well, and we support families through our Care Navigation. Our Care Navigation program is a group of individuals that I oversee. They're medically trained, whether it's a nurse practitioner, a public health worker, or a genetic counselor. When people find out that they have this diagnosis of HoFH, they're often very troubled, and they call in, and we can guide them to specialists. We can give them peer support. I can tell you, Allison has spoken to a patient of mine who was about to embark on an HoFH treatment and was frightened. And she said, you know, I've got your back. I've been on that treatment. You'll get through. And sure enough, that is exactly what happened. So I think peer support is very important. And in terms of peer support, it's not just Allison calling one of my patients or a Zoom call. We really have put our money where our mouth is, and we got funding to bring a group of HoFH patients together in less than 2 weeks. We'll be on Amelia Island. Because HoFH occurs 1 in 300,000 people, this will probably be the largest gathering in the United States of HoFH individuals. It's 18 HoFH patients and their caregivers, so it's not all 18 are not having HoFH. But we think that that will be a time for reflection. It will be a time we have a psychologist coming in to deal with the emotional aspects of having HoFH, and we will hope to empower our HoFH patients and their caregivers with scientific information on the latest studies, the mechanism of atherosclerosis, and how they can advocate for themselves.
Thank you. You know, the science on FH over the last 20 years has advanced a lot, right? Because we have better molecular diagnosis, we have ways of identifying FH individuals who have a greater risk of events, and we're in a cardiology meeting here, and we have to have a very low threshold of checking for atherosclerosis in people with FH, especially the HoFH. And I think especially with the CT angiography, can make a lot of difference for these people because we can identify plaque burden, let's say high risk plaques, etc., etc. And of course, we're talking about intensive cholesterol lowering therapies for these people, but sometimes they need intervention, early intervention, even when they're asymptomatic, and we can prevent in some situations early death. So the science has bloomed, in my opinion, right? But the thing is that when we do recommendations for screening, for therapy, we try to use those levels, 1A, 1B, and whatever. We rely on randomized clinical trials, etc., etc. But for FH, especially, and for HoFH, it's not that simple, right? Because we don't have huge numbers of patients in clinical trials. It's pretty complicated to make 1A grade recommendations. And my question to Christy is that the U.S. Service Prevention Task Force relies on things like that. But I don't think they consider the situation that we're living with FH, especially with HoFH, and then they say, oh, we don't have enough evidence to do cholesterol screening in kids. And let's talk about neonatal screening. So they say no way, right? And sincerely, I think this is no good, and they're doing things against the patients. How can you comment about that?
So I strongly disagree with the U.S. Preventive Task Force recommendations about screening, and Mary and I share this. How many of you saw the results of the randomized trial about the utility of parachutes or seat belts? So, I mean, it's just this issue of the lack of an RCT is not the same as the lack of biological and scientific evidence. And there seems to be some confusion about that. I think if you think about cholesterol screening, and this also applies to if there's a family history of high LPA, is diagnosis of a disorder early in life makes a huge difference. Now, first of all, we're talking about cholesterol for drug therapy, but remember that it's not just that. You also have other critical issues. And first of all, in terms of genetics, I always use the example of sports. So I'm from Houston, and the best baseball player for the Astros is a guy named Jose Altuve. So it turns out that when he went to try out for playing baseball, they sent him home. They said, you're too short. Now, height is genetic. It's one of the strongest genetic traits. He came back the next day. Somebody said, you got to give him a try. And he became the most valuable player in the big leagues. And they get it, if you're short, if you got bad genes, you got to play smarter and try harder. So if you tell a young child, you say, listen, you have this disorder, and you show an artery, it says, cigarettes, for you, your body would be, it's like they're going to be allergic to it. You will block up. So you can't smoke. You got to be smart. If kids are at a party and later on they're doing cocaine causes vasospasm. You don't want to be the one who has a heart attack and sudden death. I mean, it's just, you've got to play smart. You've got to be lean and be healthy and exercise. So in addition to that, the information is critical. So this thing that you can't do anything about it is nonsense. I mean, we need to get people early in life, give them the information and give them instructions of why they need to be healthy if they want to live to be an adult and have a good life.
I just want to make another comment about the U.S. Preventive Service Task Force. So Christy and I definitely share the same opinion. I don't know if any of you read the U.S. Preventive Service Task Force recommendations regarding screening children for dyslipidemia. And the first thing that I'll say is that they immediately said HoFH is beyond the scope of this document, which is foolish. I mean, how can HoFH, the most significant form of FH, be beyond the scope of the document? But I fully agree with Christy. They have, depending on randomized controlled trials in even HeFH children. It's absurd. And so we did write letters to JAMA. We got published letters in JAMA. And one thing that we pointed out is that for children, unlike adults, for children in the United States, 95% of kids have insurance, whether it's through CHIPS or Medicaid or whatever it is. And that number is about 88% for adults, but it's very different by race and ethnicity. So whereas almost all white individuals as adults have insurance, about something like 80-something% of Hispanics and even fewer Black African Americans have insurance. And so you're looking at creating disparities if you don't screen when 95% of the kids have insurance. And I mean, it's a simple thing. And actually, I will say that the U.S. Preventive Service Task Force, in its preamble, says that they are all about making sure that there's equity, diversity, and inclusion. So we commented on that as well. And it's absolutely absurd to think that we shouldn't screen, and we need to make it easier. I think point of care screening is the way to go for pediatric sites.
Actually, one of the letters bad-mouthing this recommendation was from us also. yeah, Gerald Watts, Peter Libby, and myself, we wrote a letter. It was a polite letter saying, but we do not agree with you.
Very good company.
Yeah, definitely. Okay, so Edison, I think that your statement is the most important for all of us as physicians, because, you know, since the disease is not frequent, most physicians have no idea what it is and never dealt with it, right? And I think messages like yours are extremely important, and not only for us here in the audience, but we're being recorded, so it will be everywhere with the World Heart Federation. So definitely your experience, your life can really make the difference for patients all over the world. So what would be the key message that you could convey to healthcare providers, and also for physicians, of course, healthcare professionals, but especially the policymakers, and not only in the US, but I think this message is for everyone.
Yeah, I think, so first I'll say to your earlier point, today I'm 48, and my LDL is 54. It's fantastic. Multiple lipid-lowering therapies. And if we can get children here now, before they are at 48, they won't have to go through what I went through. Open heart surgery is brutal. Living with a damaged heart from a heart attack is hard, and no child should have to go through that. I don't understand. The technology is there. The ability is there to find out who has this, and the treatments are now available to treat it and change their future. I want their milestone to be, I want to live past my mother who lived to 75, not past my father who had a heart attack at 28. So I think that diagnosis matters, and I think it changes the future for children. And we can. The ability is there.
Extremely important. I think one of the things that I said when we started this session was also about the access to therapies, right? And I don't know if Chris or Mary can talk a little bit about how this is here in the US. So about reimbursement, about accessibility. I know, for instance, in Europe, it's much easier, right, to get it. In my country, Cristina is here. Maria Cristina, she's one of the greatest experts in this lipidemia in Brazil also. For us, it's a struggle. We really try to get these therapies even for HoFH, for PCSK9 inhibitors, for instance, in Brazil, they're not reimbursed, right? And let's think about evinacumab, lomitapide, let's think about the more expensive ones. So how you guys here deal with that in the US, and how you guys, let's say, facilitate the access to the patients? Can you comment a little bit on this?
Sure. I think everybody in this room has had the experience of trying to prescribe the right drug for the right patient. And it is a challenge. Prior authorizations are never fun, but you know, and I consider myself fortunate in that I am at a tertiary medical center where I have a group of specialty pharmacists that help me with my prior authorizations. I still have to fill out a lot of them, but for PCSK9 inhibitors in 2015, it was really, really hard. It's gotten much easier. For evinuncumab, I had a patient who did not qualify for evinuncumab because she was on apheresis, and I do have to say that I wrote to Regeneron, and they got it for her on a compassionate use basis. And then when that drug finally came out, and I will tell you, she calls evinuncumab the Big E, which I think is hilarious, but she feels like, you know, it is the Big E. And and then that patient ultimately, when the drug became commercially available, was able to transition. Interestingly, I had to appeal to her insurance company, but you know, I was able to say, she's been on this drug for 2 years. She needs this drug. And so it is often a challenge. I think we should utilize our own resources within the hospital. And then all of these companies that make these agents have some services that can help us get the agents reimbursed. So you're not in it alone. You can ask for help.
I know whether Chris, you want to comment on this?
You know, I don't have a specialty pharmacist that works with our group, so it's basically document well. The FH Foundation got an ICD-10 code. Make sure you put down, if you sit down and say LDL is 250, family history of heart disease, high cholesterol, that will not get you. But if you say heterozygous familial hypercholesterolemia based upon LDL, you've got to use the documentation. You got to put the words in there. If it's FH, you got to say it, or you say homozygous FH. So documentation and then persistence. Very frequently you get denied. When you put it back in, you get it the next year. Somebody changes their insurance plan to a different drug. You got to go do the same thing again. So your staff has to be trained to be persistent, and it takes time and effort, but the patients absolutely need the therapy. And so, and they have skin in the game too, that they can also be pushing with it too. Everybody has to work, and usually you can get it if you persevere. I wish it were easier, but you got to do what you got to do.
I just also say, just a push for the Family Heart Foundation, our care navigators can help. Our care navigators are willing to call. They're willing to call physicians that, you know, need help to try to get those words that that Christy pointed out. And also, if a person is denied, they're willing to call on behalf of the patient with the patient's permission.
So we still have some minutes. I really like to open for the floor. If you want to ask a question or make a commentary, you'll be more than welcome. So you're happy with what we're saying, right? Okay, cool. Okay, so basically what I'll do is ask each of the panelists to make a final comment, and then we can close the session. Okay, so I'll start with our patient, most important one here.
Yeah, I mean, I think as somebody who lives with HoFH, to have the opportunity to address a group and to have you all here today means a tremendous amount. You know, I try very hard not to live my life as a patient, but to live as a person who is overcoming a difficult disease, and I am very, very optimistic about the future for HoFH and the treatments that are available. So I really want to thank everybody here and just ask for your help in continuing to raise awareness and to identify and name this disease so that those of us who live with it can get the right treatments.
Thanks, Allison. It's great to have you on our board, Allison. We feel very fortunate at the Family Heart Foundation to have someone as articulate as you. So what I'd like to leave you with is all of you are clinicians, and if you can go back to your institutions and raise awareness of homozygous familial hypercholesterolemia, have your colleagues keep it in their mind that if they're looking at somebody with an LDL of 400 or higher, that could be HoFH, and remembering to screen. We want our pediatricians to screen. We want our family practitioners to screen. Because so few children have physical findings associated with HoFH, the only thing you can do is screen. We know that in our registry, 44% of kids had tendon xanthomas. No child had corneal arcus, and the kids that had the kids that had xanthelasmas, just like Allison, they spend a long time thinking that they have molluscum contagiosum, a benign pox virus of childhood. And we have one family that waited 2 years. This child's molluscum just wouldn't seem to go away. In fact, it got worse. And it was a 2-year delay for making that diagnosis. So if you think it's molluscum, make sure it's not HoFH. And, I just screen, and keep this in mind.
So knowledge is power, and we need the knowledge. It's a very simple test. Get a lipid profile. You can do a finger stick. You can do it at home. It's an inexpensive test, and we need to do it. And all adults should know what their cholesterol is. Hopefully you diagnose the heterozygous. I think all children should have it tested. I strongly disagree with this, the task force for that. And it was mentioned, if there's a family history suspicious, this needs to be done by age 2. And I would favor genetic testing at birth or blood spots also, and for advocating for this in your state. But the knowledge is the key. And if we can make the diagnosis, we can change profoundly the course of the disease.
And the good thing about screening cholesterol in children is that most situations, if it's very high, it's FH, right? There's not such a contamination of environment, diet, etc., etc. And also we have evidence that if we do the cascade screening from down to high, from the kids to the parents, it's much more effective in finding people with FH. So I think this is a strong message. And as I said in the beginning, now we're living very interesting, exciting times for people with FH because of facilitation in diagnosis, the amazing therapies that we have. But if you don't make the diagnosis, if you don't screen, if you don't check the families, and if you don't treat, we will not change the natural history of this disease. I really like to thank you guys who are watching us here. I also thank Regeneron for supporting this, and this initiative of the World Heart Federation is extremely important because definitely we have to congregate the different people or the different societies and with the common goals, and we really we might have the power to really change this disease. So I really like to thank you very much, and I wish you a nice continuation of the Congress. Thank you.